Hi everyone, greetings. How are you all?
Greetings, Priya. We just check that my audio visual is working okay.
Yes, sir, we can hear you well and we can see you well as well.
Right.
Thank you so much
Then,
for joining, sir.
then I'll just share from my existing slide deck. I think that's going to be
Yes,
safest.
yes, that I'm sharing with you in 5 minutes, sir.
That's a little bit tight, so maybe we have to use my original. We'll see. Okay.
Yeah, sir, I'm just waiting for 5 minutes more. If I am failed to share the updated deck with you, then I'll request you to share the original one. I'm just
Okay.
waiting for 5 minutes more.
Okay. I'm just concerned that we don't reduce the font sizes. Yep.
I know, sir. It's been
All
late
right.
from my end.
Okay. Then while we're waiting, if there are any questions around procurement and module 4, please put them in the chat box and I will do my best to answer them while we are waiting. Any questions on module 4 and any questions around institutional procurement for health products and pharmaceuticals? It looks like we have a few people with us from the French language course. I'm sorry, today will only be in English. My French is not good enough to do that. Okay, one question that is there. What's the difference between market shaping and pooled procurement? Okay, so let's start with pooled procurement. That is bringing together all the requirements to one place. So we could start with a simple example. In Indonesia, 5 different organizations buy vitamin A. That's really a nonsense. They should pool their requirements and all buy it together for the country. That would be pooling. You can pool between countries. So the Eastern Caribbean islands have a network where they pool their requirement and they buy it for all the islands en masse and then distribute it around the islands. Gulf Cooperation Council in Arabia, all along the Gulf Coast there, all the Gulf Cooperation Council countries issue a joint tender for all their requirements, about 11 countries. That's pooled procurement. Market shaping comes around when there isn't a market or the market is not functional. So if we look at the new drugs for MDR-TB, the manufacturers weren't making them. They were new. They were reluctant to make them because nobody was buying them. So market shaping is about encouraging the manufacturers to make them. And we have a list of about 7,000 orphan drugs. That's drugs that are used to treat a low number of people. The manufacturers don't want to make them because there's just not enough people with that disease. It's not profitable to make the drug. That's when we go to market shaping to encourage the manufacturers. So for example, for leprosy treatment, the leprosy program has been a big success. There are only about 250,000 cases of leprosy in the world at present. So all the drugs are made by one manufacturer, which is Novartis out of Denmark. They in fact donate all the drugs free of charge for leprosy. That's market shaping. I hope that helps explain the difference. We have a few seconds while we're waiting for people to join. If there are any more questions, I'll try and explain. So you can type the questions in the chat box. Okay, then I'll see you in a few moments. Okay, I see we have a few more people waiting to join us, so we'll just wait another minute and then we'll start. Okay, Priya, I see we have 40. Are we expecting a lot more people or? Okay, I think we had better start. Firstly, welcome to all and everyone. We're very pleased to join you today. This expert session where we offer the opportunity to ask questions. I'll just take you through the housekeeping and then we'll go straight into the presentations. So this is a expert session around module 4, which focuses upon institutional procurement for health products. So please mute and turn off your video unless you're asking questions. You can ask questions at any time by typing into the chat box and by raising your hand. We will have 2 sessions to ask questions. When you're invited to, please turn on your video and sound and ask the question. But you can type questions at any time in the chat box. The webinar is recorded and the recordings will be available to you, and all the slide deck will be shared with all of you. The meeting is also being live streamed on Facebook as we speak and will be available for Facebook on the recording after this session. The main object is to allow you to ask questions, and I will try and answer them as the resident expert. I will summarize some key points around the module, and I'm going to try and expand on the module because we've had such a large impact by COVID. It's really changed how we look at procurement. So I'm going to try and bring home some of those points that have changed our outlook on procurement and give you a chance to respond to what you think my assessment of that situation is. So the first, a presentation, and I've called it an upside down presentation because I'm going to give you the answer before I ask the question. And I'll explain why in just a moment. Then in about 30 minutes time, we'll have around a 15-minute session to answer all the questions that have come up in the chat box and any other questions you have. Okay. Okay, I hope you can hear me again now. Okay. Then a second session to see how COVID has impacted procurement and how we can make procurement work in a post-COVID world. And then the second Q&A session for around 15 minutes. Okay. I'm sure by now everyone knows who I am, and you're probably bored hearing about me. So I'm one of the authors that wrote the Yellow Book, the MSH WHO manual, and also managing drug supplies and many other publications and sections. More recently, I wrote the COVID training modules for supply chain responses for the Global Outbreak and Response Network for WHO in Southeast Asia for COVID-19. That training is available to you for free if you should want it, and we'll give you the links a little bit later. Okay, so this is my upside down presentation, and I'm going to give you the answer before I give you the question. And that's really because of the huge impact that COVID has had on the healthcare supply chain and how it's massively changed perceptions, how we look at things, and the willingness for action and change. So I believe it's now possible to address many of the long-standing issues we've had on public health procurement and make it a lot better for the future because of COVID. I hope some good can come from it. If we look at the impacts and try to analyze what COVID has meant for the healthcare supply chain, especially in public sector, low-income countries, the analysis by JSI, John Snow International, the link is on the screen, says that there's going to be a lot more funding sources. We're going to have to work with a lot more new donors. There's going to be more procurement through the global donor systems, like the Global Fund WAMBO system, like the UN system. We're going to have to work with a much wider range of manufacturers. We can't keep this narrow focus that we've had in the past. And there's going to be a massive change in regulations. And the good news is there's likely to be a lot more money for supply chain operations. So my key message here is let's try to use the impact that COVID has had on healthcare supply chain to drive major reforms in public health procurement. So the answer to the question I'm going to ask at the end is try to be aware of the current situation on public health procurement and its many shortfalls. Be aware of the mindsets and how COVID has forced a change in how we look at procurement and how other people look at it, especially the finance people. We need to understand what public health procurement is, and since you've all completed Module 4, I believe you can all do that, and what it needs to make it work. And we need to be ready to advocate and promote solutions for public health procurement to make it work effectively. If we look at the current situation, we see that it's improving, but it's not that good. Organizations like the Global Fund and the Gates Foundations have spent millions of dollars, and we're not seeing that much better healthcare. We're not seeing that much better results. And part of that is the procurement process is failing. We're using archaic methods. Some of the methods are 2,000 years old. They were used by the Roman army when they had legions marching around the world. They are archaic. They don't work for us. And we have to recognize this shortfall and be prepared to address it. If we look at the overall situation, and this is from a study by the Global Health Center, we're seeing that low-income countries are paying far higher prices than the high-income countries. You keep buying expensive medicines. You keep buying branded. We've talked about generic medicines through all our modules. It's a 40-year-old idea, generic medicines. We're still buying branded medicines. There's not much competition among the suppliers who respond to our tenders. We're buying all the medicines from the same place. If we look at some of the results, the graph on the top shows the kind of prices that we're paying. We're paying more than the private sector for medicines in the public sector. And we look at how we're buying, where we're buying them from. We look at Zambia down the list here, asthma medicines, 100% from one supplier. Contraceptives, 98% from one supplier. Lipid regulators, 98%. We're buying all the medicines from one supplier. Where is the competition? How are we going to get good prices if there's no competition? If we look overall, we have a whole series of problems. We've got institutional regulations and the Ministry of Finance and all the different restrictions on us. We don't have enough capacity. We don't have enough staff. We don't have enough trained staff. We can't manage. If I can ask you to mute, please. If we can all mute. Okay. And the list of problems goes on. We don't have good market information. Difficult for new suppliers to enter our countries. We don't have a common system. We don't all appreciate preventative measures in the same way. We don't really accept agents for purchases. We have anti-competitive behavior, not deliberately, but that's what happens with some of the procedures that we're using. So why is it so hard? Why is it being done so poorly? We've been doing procurement for decades. Why is it so difficult? Well, there are many reasons. But first and foremost is a lack of support and recognition. Then almost no health professionals want to follow the procurement system. The doctors and the nurse, just buy it, just bring it. We don't want to hear about procurement procedures and regulations. Just buy it. We've got a lack of economic reality. We're trying to work on a global market when we have very low buying power. We're using archaic, decades-old systems which are inappropriate and dysfunctional. We're trying to use the same procurement approach for everything. X-ray machine is not the same as aspirin. It requires a different procurement approach. Yet I've only got one procurement manual for everything. And we don't have enough skilled and trained staff. Let's try and explore some of those areas. Lack of recognition. Well, we have a statement here saying, yep, it's not recognized. Procurement is underappreciated. Published documents, not just the white-haired old professor telling you. This is published out there. It's not recognized. Everybody thinks that it's just procurement, it's not important, it's not there, it's just do it. That's changing, and COVID is changing that. We've got rules and regulations which are not adequate for what we're trying to do. They're not built for the modern world. We need extra procurement capacity. The lack of support means we have not got the legal regulations, the financial regulations that we require. We're often trying to issue letters of credit through archaic banking systems. We're not using electronic transfers, which the rest of the world is doing. We're looking at this, making it a lot more complicated than it needs to be. And that means that I need a lot more trained staff to make it work because it's so complicated and difficult. Everything I do is a complex process. Good procurement practice, you all know from Module 4, the WHO principles for good procurement practice for pharmaceuticals and health equipment. Long published, all there. But nobody ever wants to follow it. Nobody ever wants to do it. Why does nobody want to do it? Well, many of you are pharmacists. Did you learn the WHO good procurement practice at pharmacy school? Not many teach it. No medical and nursing schools teach it. They don't know anything about it. It's not taught at many management schools. And we have to try and bring this understanding to all the colleagues that we have to work with in the healthcare activities. Procurement is not just buying. There's a lot of activities around procurement, and all of that's encapsulated in the WHO operational principles for good pharmaceutical procurement. We have to make that known. We have to get it into the curricula of medical and nursing schools and pharmacy schools to make sure everybody knows and understands why it's so important and what we are trying to do in procurement. Economic reality, and this is from module 1 really. If we look at the pharmaceutical expenditures you're undertaking, if we look at the graph on the right, we see that high income countries are spending about $400 per capita. But down in the low income countries, we're only just one dot above zero. That's what you're buying per capita. And the middle income countries are about 10 to 15. The average for sub-Saharan Africa is about $15 per capita. The USA buys $1,000 per capita. So my point here is that the high-income countries are buying 40 times more medicine than you. 40 times, 4,000% more than you. Okay? The low-income countries are about half the world population, and you get 2% of the world medicine. That's the hard economic reality. What does that mean? Well, for a low middle income country with a population of less than 10 million, let's say Botswana, Lesotho, Namibia, all the Pacific Islands, all the Caribbean, then you as a country are trying to buy less than one hospital in Europe. One hospital. They're buying more than your country is buying. So why are you trying to use procurement procedures that were designed for high-income countries in low-income countries? You're trying to use a sledgehammer to crack a peanut. Some donors have already recognized that and started to put in together pooled procurement and virtual procurement mechanisms. And the COVID UN WHO procurement mechanism is a fine example of having to pool procurement. As a country, you're just not buying enough because you don't have the population and you have a low income level. We need economic reality to understand on the global market, you are a minute player. So we need systems that work for minute players. And there are good systems, and the WHO good procurement practice has them built in. Archaic procurement procedures. Lots of statements here. There's archaic procurement methods not developed in 50 years. We're using the same method. The private sector has gone all electronic. We're trying to use books and ledgers and ink and old-fashioned systems. We use this term archaic. We look at a situation. We haven't changed it since colonial times. For the Anglophone countries in Africa, they inherited systems from colonial times. They weren't built for your country. They were built for the colonial office out of London, what they wanted to achieve. And we're still saddled with them. We've still got them because we haven't changed the laws and the regulations to make it appropriate for our country. For the Francophone and Lusophone countries, they have similar problems. They had colonial systems, they inherited those systems. We look at the situation in Rwanda, the Minister of Health can't sign the purchase orders. Ridiculous. But that's how it is, because that's the old systems that need to be changed, that need to be reformed. How many of you have a separate procurement manual for different commodities? Probably got a procurement manual, but it's one size fits all. There are 18 different guidelines for procurement manuals for health products published by WHO. There's one for X-ray equipment, there's one for cardiac equipment, there's one for medical devices, there's one for diagnostics, because they require a different procurement approach. And yet we're not using them. We haven't developed them. We're trying to use the same procedures for everything. They're archaic and they're not appropriate. Good guidelines are available. How many countries have them? Less than 20%. Even though guidelines are available, even for medical devices and diagnostics. You're all buying diagnostics, you're all buying medical devices, you're trying to use the pharmaceutical procedures to buy them. It's not really appropriate, doesn't fit. What about equipment? Why are you buying equipment? Because we've always bought it. What about rental and lease and pay-per-service options, which are used throughout the private sector? They're all possible. Public sector procurement permits them, but we're not using them. And we have to change the mindset here on how we go about procurement. Lack of skilled staff. Well, the point here is to get skilled staff, trained staff. And that's a problem. There's lots of reasons why we don't have trained staff. And I'm sure you are well familiar with that. We don't have the performance incentives. We don't have the salaries that we need. We don't have the structures that we need. Yeah, if I can ask you to mute, please. The staff shortages are a bit different in Southeast Asia than Africa, but there are shortages throughout. And there's generally reckoned to be between 30 and 70% staff shortages in public sector supply chain and procurement. So I need a lot more training. The point about this is I need specific training. And here we have from people that deliver, the NGO linked with IAPH, making the point that it's got to be health specific. Yeah, if I can ask everyone to mute, please. If you can please mute, yeah. It has to be specific for healthcare, and it has to be specific for low-income countries, and it has to be specific for the job functions you are doing. There are lots of good training courses for procurement. CIPS, Institute of Purchasing and Supply, is an excellent training course, but it's not specific for health. It's not specific for low-income countries. The training needs to be health and low-income countries. And of course, the course you're following is exactly that. It's 100% health, and it's related to low and middle income countries. Now, I've given you a whole pile of problems and issues. So it sounds like I'm saying, throw out the whole of procurement and let's do something else. I'm not. What I'm saying is we need to change the way we do procurement. The good procurement practice from WHO is entirely appropriate, entirely needed, entirely useful. It's the way in which we implement it that we have to think about changing. And I'll talk about that in part 2. But now it's time for questions. Please type in the chat box any questions that you have, please. I see we've got 8 here. Okay. Please share the PowerPoint slides. Yes, all the slide deck will be shared with you so you get all the links. Should we be relying on national procurement or explore further decentralized procurement? Right, okay. National procurement depends on the size of your population. If you're Nigeria with a population of 200 million, frankly, you can go on issue national tenders. If your population is below 20 million, you're probably going to struggle on the world market. It's going to be a real problem for you, and you need to look at it. Decentralized procurement can still be run centrally. Well, that sounds a bit strange, doesn't it? It's done in Thailand, it's done in Indonesia. So the central government awards the tenders, but doesn't actually buy anything. So it does all the selection of the suppliers, it agrees all the prices, but the individual budget holders, which in Thailand are hospital and districts, they buy the medicines through an electronic system run by the government. Exactly the same in Indonesia. It's called the e-catalog. I presented on it last time at the start of the module. So nationally tendered, but locally procured. It's operated through that system. Both Thailand and Indonesia do that. They're both large population countries, so they can do that. For smaller countries, you generally need some kind of regional pool procurement. Okay, let's have a look at another question here. Why are there still challenges in domestic procurement in country medical supply chain agencies? I've just given you a big list of why there are so many problems. The status of procurement is not recognized. The support systems are not there. There's not enough trained, skilled staff. Let's look at some more questions if we can. How can I harmonize national suppliers? Difficult to harmonize national suppliers, but you start by having a clear policy. What is your national policy? So in Indonesia, they have a clear policy. They have 4 in-country manufacturers. They have a clear policy to buy from those if the price is not greater than 20% above the international guideline price. So they've got a policy that helps the local suppliers to plan, helps the local suppliers to produce. We start with clear policies. Once we've got those clear procurement policies in place, we can harmonize with national suppliers. We can help bring them along. But we do need a clear policy. How do we convince the government to adopt new procurement practices? Right. I think the answer to that is COVID, COVID, and COVID. COVID has really had a massive impact and is really starting to change mindsets, to get people to understand how fragile the supply chain is. And if we don't strengthen it, it's going to collapse. So it is possible now, it is some hope that we can succeed in changing approaches to procurement. Even a year, 2 years ago, we had little chance. Now, because of COVID, we have a much greater chance to try and change how we do procurement. The OECS uses computerized procurement for 9 member states. Yes, it's one of the great success stories in regional pool procurement. Probably the largest is Gulf Cooperation Council with 11 countries, but they're at much higher spending levels in the Middle East. So Caribbean is closer to low and middle income country level. It's a big success story. It works well. Sadly, SADC, or Southern Africa, has not really taken off as a pool procurement agency. How can we address the needs of donors? Sometimes they impose a geographical area in which you can obtain your products. Yes, donors follow the golden rule. The golden rule is the one with the gold, they make the rules. So sometimes you have to buy. British aid is now untied. It doesn't follow that. European Union aid is still tied. So it is a problem. It comes with the territory. We have to work with that. If they're bringing the money, we have to follow their rules. There's not much we can do about geographical preferences. Waivers are usually possible, but they're difficult and complex to undertake. Fragmented procurement has led to a proliferation of medical devices, which complicates. That's why medical devices procurement is different. You have the Maputo Convention, in which it was agreed for laboratory equipment. Certain laboratories equipment would be standardized across the whole of Africa, and your country probably signed up, but nobody probably told procurement that you signed up because it was done by the lab people. That means you're going to buy all the same equipment so that it is standardized. You're going to buy only the WHO pre-qualified diagnostics, so it is standard across the country. So you've got a chance of obtaining maintenance and spare parts and support That's the Maputo Agreement. Look it out, see if it applies to your country. Generally, it's Africa. It's not been followed yet in the Caribbean or Southeast Asia, but I believe it's coming soon. So there are steps moving forwards on that. Since procurement is based on countries' EML and they have their own procurement, how does pool procurement work? Well, in fact, most essential medicine lists, around 300 items, are exactly the same. You find that usually there's probably less than 20% variation. So you can pool the items which are common to all countries. It does work quite well. Example is the Caribbean service, which has been operating exceedingly well. We just heard 9 different countries involved. That works really quite well. How can I integrate the national health procurement system into the one system example, humanitarian health programs supply in the country in Somalia? Frankly, you can't. Humanitarian supply will always be different because the time ratio is different. They will supply kits when you want to supply regular items. All you can do is try and coordinate together. Integration is probably too hopeful at present. They're just too different in their operation. Procurement through the portal service for lab diagnostics PPE goes through a registration process. It guarantees quality and medical equipment. That's quite true, it does. That's one of the advantages of operating through the global procurement mechanisms. You lose a degree of sovereignty, but you gain on assurance of quality. Is there any program or study or strategic document that we can use to illustrate the effect of COVID on procurement systems to the government to help change? Yes, there's a course coming from Empower. We'll come to you very soon. In the meantime, there's the Goan course, which is available free online with all the documentation from WHO there. We'll give you the links to that course. Let me just check on the time. 20:04, okay. Think we can have another few minutes? Yep. Okay, if there are any more questions, please put them into the chat box and I'll take any questions on any aspect of procurement in module 4. How can public and private health procurement work together? In lots of ways. Okay, let me give you a simple example. In Indonesia, they have a system called the Barraclough program. So the manufacturers, in-country manufacturers, obviously want to make branded products and sell them. As part of the agreement, they must also make generic products available at the government price. So every drugstore, every retail pharmacy in Indonesia, as well as the branded products, it must carry the Barraclough, which is the government approved generic products. These generic products are screened. If you can mute, please. These generic products are screened and for quality by the government. So that's one way of working together with the private sector. You can pool procurements with the private sector. Often the private sector is buying different products. They want the brand name products. But you can still undertake a degree of pooling with the private sector on some items. It's worth following through. It can come together. Social marketing is another way that you can work effectively with the private sector. That's been done with antimalarials in a number of countries in Africa and Southeast Asia. Give just another minute and then I'll go into the second presentation. Inventory management and rational use of drugs comes in module 7, I'm afraid, so that'll be a little while before we get to that. WAMBO for negatively impact in domestic procurement? Absolutely, it does. Yeah. Countries' abilities to manage the health system, I would doubt that. The reality of this is, if you're going to go on the global market with low buying power, how are you going to command successful operation? You have no buying power. That's the reality of the situation. COVID's brought that home. The whole situation on PPE. How many fraudulent and fake products were around there? Everyone said they can make face masks. Very few of them comply with the specification. It is difficult. You need a clear policy to support your local manufacturers. You start with that. And that's where you put part of the money. But in part two, I'll try and explain some of the systems you can do to help support the local manufacturers. But understand the global mechanisms which organizations like the Global Fund are forcing onto countries is because they recognize countries don't have the buying power, and they're not getting good prices, and they're not obtaining quality items. It's an issue, and it's their response to addressing it. If countries wish to undertake self-procurement, I well understand that they do, you have to have the ability to have buying power and regulatory control. And regrettably, very few low-income countries do. That might well change with COVID as the status, as the recognition of the importance of procurement comes along. We can hope for change. How can low middle income countries build resilient and sustainable supply chain? Coming soon, about 3 slides time. Okay. All right, so I'll stop there. We go back to the presentation and we'll have a second Q&A session in about 30 minutes. So how has COVID changed things? It's changed the mindset. Supply chain is far more recognized now. We look here, in October, just a few days ago, the American Hospital Association is talking about the supply chain, a huge conference, being a strategic partner in healthcare delivery. They never talked to supply chain before. The doctors weren't interested in procurement, just bring us the stuff. Yeah? Now they're recognizing the importance of supply chain to deliver the products. Procurement security, the resilience, is now far more recognized because of COVID. The need for trained staff is far more recognized. And we're starting to see a bit more economic reality because of the impact of PPE, personal protective equipment, and the COVID pandemic. It's starting. It's not massive, it's not huge, but it's there, and it's an opportunity, I believe, we can use. What's been the impact? Major supply chain disruptions. It's been severe, and we're seeing an increase in drug prices, which have got nothing to do with COVID. We're seeing generic medicine prices rising. And that price range analysis by UNAIDS indicates it's around 10 to 25%. That's how are we going to manage the budgets next year if all the prices have gone up? So we've got to think quite a lot about the way in which we're going to undertake procurement because of the impact of COVID. And if we look at the impact, what's the impact of COVID? Well, here's a published report from Pam Steele. Links on the screen. You see the areas are supply chain planning and procurement. That's where COVID's had the biggest impact, around procurement. And I want to suggest we try and lever that impact to our advantage. What are the predictions? Well, market disruptions, we're still seeing some of that. We've got to diversify, and that means onshoring, bringing the supply base closer to us. This global supply chain is all very good, but bringing everything from India, we've seen what happens when we do that. We've had some hard lessons from COVID. We've got to look at supporting local sources a little bit more. Technology is changing. We've got to be far more flexible and responsive. We can't start issuing 2-year tenders when we're in the middle of an epidemic. We have to be much more flexible. And we need a lot more money investing in training and support for supply chain. You asked me about resilience. Well, for nearly 30 years, all the drive in procurement has been for efficiency, lower prices, lower cost of the procurement unit itself. Just a tiny number of staff undertaking million-dollar procurements. It's all been about efficiency. And that efficiency has made the supply chain very brittle. Slightest disruption, supplier delay, and we're in real trouble, real problem. We've got to get back to a balance between efficiency and resilience. Not all efficiency, not all resilience. We need to be more resilient, but don't go overboard to total resilience and then have inefficient systems. We've got to try and balance the two. And part of the problem is we've been linked with this unreal requirement. We want everything fast, cheap, and good. You can't do it. You can only ever have 2 out of 3. You can have fast and cheap, but it's not good. You can have good and fast, but it's not cheap. You can't ever have all 3. And it's time to dump that approach because it's impossible to achieve. And we go to a balanced approach where we have agile, and that means timely, and that means good planning. We get products in time, not fast, but timely. Not cheap, but cost effective. Not the lowest price, but the lowest total cost of ownership, including having secure and reliable suppliers over the long term. Not good. Good would be brand name. We want assured quality. We don't want the brand names. We want verified quality to international standards. If we change to this balanced approach, agile, cost-effective, assured quality, we can achieve all 3. We do it regularly, but we need to adopt a risk management approach in order to achieve that balance. How do we measure agility? Well, here are a few places where you can measure agility. I'm not going to say much more about it, except there are established tools in how you measure how agile your procurement is. Have we got agile systems now? No. These systems were developed 50 years ago. They weren't any good then. They're certainly not good now. But the point around it is that's restricting me. I can still use good procurement practice, but I don't need these restricted systems around me. The supply chain, we've got to move this away from this decades-old design that's hampering us operating. So how do I get this? I've got to redesign and invest in this agility and flexibility. Key point here is new technology is going to help us, the computer systems, the other electronic access, but it's not going to solve all the problems. The technology alone will not bring all the solutions. I need to change the way we do procurement. That means changing the systems. And to do that, I've got to have a skilled and trained staff. Is it possible? Yeah, Ghana's shown it with the supply tower success. Tanzania with immunization supply chain has brought agility. Is it possible? Yes, it is possible to make these changes. How do we make the systems more resilient? We can do split tender awards. South Africa's been doing it since 2015. Yet how many countries are doing split awards? Typically 80-20. It's just the lowest price takes all. Lowest price on the tender, 100% commodity award. That's not resilient. That's high risk. If we use a risk management approach to identify the high risk products, then we can look at a split award. That's how we bring resilience. Split awards cost money. This is data from Uganda. If we look at the lowest price, we've given that a score of 100%. The second lowest price was 60% more. So if I did an 80-20 split between the lowest and the second lowest tenderer, it's going to cost me 119%. So it's going to cost me 12% more to do an 80-20 split. But that increases my resilience. This is our point about not the lowest tender price, the lowest total cost of ownership, the lowest total cost. If that first supplier defaults, what am I going to do? I'm out of stock. Patients are dying. So to bring resilience, I do split awards. Most countries allow it, but we don't do it because it's difficult and complicated and the Ministry of Finance don't like it. But we've got to try and bring that understanding of cost and total cost of ownership. And that's how we get development of local suppliers. We might put 80% through WAMBO, but perhaps we could do a 20% award to the local manufacturer. That's one way to consider on split tenders, how we go about it. So the key point around that is for risk management. Recognize the need for risk management. We'll talk more about it in later modules, how we do it. And the key point here, evidence-based, not just what I think, not just what this old professor told me, evidence-based. And I try to do that throughout our course, and we give you published documents. And we learn from examples in different countries how we go about bringing risk management and resilience to our procurement and supply chain. One of the ways we can reform is to use the Pareto principle. Many of you already know this. It's called the ABC system. And what this states is that 80% of the cost comes from 20% of the medicines. And this is the long-established management principle. So 20% of the medicines, they account for 80% of the budget. The other 80% is only 20% of the cost. So what I'm saying is, it doesn't matter in a cost sense if I pay double the normal price for the aspirin, because that's in the 80%. It's got no cost impact. If I pay 1% more for the ARVs, that's a big impact because that's in the 20% of all the high cost. And recognizing that tendering bidding is expensive. I've got to employ all this staff to do the tender documents. I've got to have a tender committee. I've got to have analysis. I've got to have the contract award. I've got to put all things in place. So why am I doing for this 80%, which is only 20% of the cost? Why am I doing a tender every year? I should only be doing a tender once every 3 or 5 years because it's low cost. The tendering, the competition, is not going to make much cost impact. I should be focusing on the 20% that costs all the money, because that's where I get all the cost savings and all the economic impact. If I focus on that 20%, I'm going to get a much better cost benefit, and I'm saving money on the tendering. So this ABC analysis, this Pareto principle, we'll talk more about in later modules. But basically, 20% of the medicine is 80% of the cost. And here is an example from Indonesia, where you can see just 18 items from their essential medicine list is 70% of the cost. Just 18 items. And they have an essential medicine list of 400 items. So typically, around 30 drugs, just 30, out of your essential medicine list of perhaps 400, cost 80% of the budget. So those items, I should be tendering every year. I should be keeping a really close eye on the market and focusing all my procurement efforts on. The other 80%, economically, they're not that important. I can tender them every 3 or 5 years. It's enough. I don't need to do a tender every year. That's one of the key points of changing the way in which we do things. Good procurement practice from WHO requires that we tender, but it doesn't say we have to tender everything every year. We can think about tendering some items every year, the A group, the high cost items, but the other items just once every 3 or 5 years. And my chart of ABC analysis showing 20% of items at around 80% of the cost. One of the other lessons from COVID is those countries who performed best on COVID used multiple procurement mechanisms. They didn't use all self-procurement. They didn't use all global mechanisms. That's the CSCS, that was the UN procurement system. When they split the procurement mechanisms, some global procurement, some self-procurement, some through bilateral donors, they got the best results. The message here, there's no one size fits all. There's not one method that's going to work for everything. Different approaches, don't put all your eggs in one basket, use different procurement mechanisms. And World Bank has gone so far as to publish its fast-track procurement system, originally for COVID, now well established for all pharmaceutical products. You don't have to have World Bank money to be able to use the World Bank fast-track system. So what's my overall message? There's no one size fits all. Healthcare procurement needs to change, but change is around the way it's implemented, not the basic WHO good procurement practice. There are many procedures available to us: pooled procurement, fast track, agile, split awards, framework contracts, prime vendors, and we're not using them. We have to look at them to see if they might be appropriate for our country and what could work in our country. It's time to move away from these archaic implementation mechanisms and into the modern era. I started by giving you the answer. Now I'm going to ask you the question. And the question is, what's this got to do with me? I can't change the procurement policy in my country. Not even the minister can change the procurement policy. That's got to be discussions with the Ministry of Finance and the procurement unit and the Parliament. No, you can't. But you can be ready to take advantage of the change in the mindset because of COVID. You can try to change the way in which procurement is implemented while still following all the rules and especially good procurement practice from WHO. You can be ready to use the increased funding which is coming into the supply chain because of COVID. And you can spread the message on the need for quality health procurement training that's specific for health and low and middle income countries. That's the question. I've already given you the answer. Now, go and spread the word. You've all completed module 4. You know how to do procurement. You know what good procurement practice from WHO is. Now think about different ways of implementing within GPP. Okay, time for our next Q&A session. Let's have a look down the list here. Okay. Policy or solely government control, how can we come to help for changes? Private sector can lobby. Some of the regulations also extend to the private sector. It limits what the private sector can do as well. But it's worth lobbying for change. Why has the prime vendor model from Tanzania never scaled up in other countries? Because it's been beset by corruption, particularly in a number of countries. It's not always worked well. We would like to see more of it in use, but it does require very stringent oversight and regulation. And I think that's probably why it's not scaled up, because we don't have the kind of financial oversight and regulation and control that's needed to implement that model successfully. Does bundling of related products lead to cost and efficiency savings? Well, it can do, but it's not always the case. So it depends very much on the product. For vaccines, does bundling of vaccines and syringes and sharp boxes all together, is it cost effective? Yes, but it doesn't lead to any cost savings. It's just more efficient to have it all together that way. If we don't tender how do we get the commodities we need? I'm not advocating abandoning tendering. I'm advocating the frequency. So for the A group, for the 20% high cost products, they get tendered every year. The B and C group, 3 to 5 years. So they're still being tendered, but they're tendered on a longer term contract. Outside of that, if you are a low population country with low buying power, you might look at the global procurement agencies like the WAMBO, like the UN system, like procurement through UNICEF. That's how we obtain the items that we need. Can we have a simpler or cheaper process for manufacturers on WHO PQ process? We wish. We wish. I think the simple answer is no. To get WHO pre-qualification currently costs about $200,000 by the time you've done all the certifications and everything. But the problem there is that's because the manufacturer wasn't ready. If the manufacturer is ready, for example, in most of the high-income countries, which have a stringent regulatory authority, the manufacturer already complies. It doesn't cost them $200,000 to get WHO pre-qual because they've got everything ready certified. It's usually the manufacturer has to bring his standards up to. So I don't think that's likely to change in the near future. We want a different PQ system focusing on alignment and building their industries. I think that's unlikely. The reality of pharmaceutical manufacturing is that it's going to take place in the high population countries. India has a population of 1 billion. China, more than 1 billion. If we take one of the larger countries in Africa, Nigeria is 250,000. So India is going to make 4 times more. How are you going to compete? How are you ever going to compete on price with countries the size of India and China? If you want manufacturing locally, you have to be prepared to pay much higher prices. Everybody says they want local manufacturing. The moment it comes to pay, then nobody wants to pay. Everybody wants the cheapest possible product, which means from India and China. So until there is major change, there's not going to be a change. And LMINCs are not likely to get much outside of India and China on WHO pre-qual. We take the situation of Indonesia. There are 4 manufacturers in Indonesia, 4 major drug manufacturers in Indonesia. None of them have WHO pre-qual because they know they will never get the business. Why? Because they will get WHO pre-qual, they'll never get any orders because they're more expensive. They're manufacturing for a domestic population of 250 million. India's manufacturing for 1 billion, 4 times more. Their scale is so much more, their cost saving is so much more. That's why even manufacturers that can qualify won't bother because there's no business, because they cannot compete on price with the likes of India and China. So if you want to build local manufacturing, be prepared, upfront commitment to pay more for medicines. Is it possible to, yes, you will receive all the slide decks. Always, we give you all the slide decks with all the links. Updates for the masters. We're really trying very, very hard to get the master's course up and running. Believe me, we are just going through so many hurdles and loops and certifications and approvals. You can't believe what it takes to get a master's program. We are hopeful this year, but the course is ready to go. We could press the button and start tomorrow. Getting the approvals, that's another matter. We have spent an awful lot of time to get the approvals and the course recognized. Until then, we can't release it. Can we get offtake agreements or volume guarantees to build local production? Yes. The use of variable quantity contracts, normally in the range 80 to 120. So you guarantee to take 80% of a nominal volume and up to 120 at the same price. That is possible. It is permitted within good procurement practice. It's a recommended technique for some items. Certainly, framework contracts are in massive use in Indonesia and in Thailand. It's all electronic, it's all done online, online bidding and online ordering. So the central government doesn't actually buy anything, it just manages the process, and then the individual budget holders place at the agreed government price. I haven't received the slide decks for the session so far. I'm sure if you email Priya, you will get that.
Thank you so much, sir, for this lovely and a better, good expert session. In fact, I really enjoyed this module 4, and now I am starting understanding what all modules and chapters are in our courses. So thank you so much for your time, sir. Plus, we will be sharing the sessions recording on our YouTube channel. So please make sure to subscribe so that you can get the latest updates regarding the recordings, and the slides will be shared with you on YouTube itself. So we'll let you know once it is updated. Okay, we'll let you know on email or WhatsApp. Thank you so much.
Right. Okay, and then I'll just take the last 2 questions. We should do a session on manufacturing in the health sector. I'd be happy to do that, but it's rather negative, I'm afraid. It's going to be that you cannot compete with India and China. If you're going to do it, you need political commitment to pay more. And I have never found that forthcoming in any country. Big manufacturers in Africa, you don't have the population. If you take the total population of sub-Saharan Africa, you're not competing with India and China. It's not there. Even if you take all 54 countries, you don't have the competition with India and China. That's the reality of the production technique. COVID vaccines would have to be a separate presentation altogether. The reality of COVID vaccine manufacture in Africa is highly unlikely. Okay, we're over time, it's 36, and Priya, are we going to close now, or are we going to carry on taking questions? What do you think?
I guess we can close the session, and if there is any further questions, please feel free to ask on discussion forum, or you can email me on my email ID. I will forward the question to Andy, sir.
Okay, then I wish everyone a good night. If you're traveling, a safe journey home.
Thank you so much, sir. Thank you.
Okay, travel well. Good night.
Thank you all for joining the session. See you again. Bye. Take care.